Have you ever met a child like this? No fever, no obvious liver or spleen swelling. The brain MRI says, no clear abnormality. But starting in kindergarten, something slowly begins to slip. Like life is dropping frames. Learning gets slower. Behavior gets stranger. Then comes seizures, unsteady walking, trouble swallowing. Most families hear the same labels first. Learning disability, attention problems, ADHD, autism spectrum disorder, depression, schizophrenia spectrum, teen onset psychosis. Because those diagnoses are common, and honestly, they look like a perfect fit. But sometimes the real answer isn't psychological, it's cellular. This condition is called Niemann-Pick disease type C, or NPC. A genetic metabolic disorder that can wear a psychiatric mask while quietly driving neurodegeneration. Today, I'll walk you through 2 real patient cases, and we'll map out the clues that are easiest to miss. Slower learning, declining planning and executive function, gradual loss of language, seizures or unsteady walking, and finally, one critical sign, slow vertical eye movement, VSGP. Chapter 1. The first child. He didn't crash overnight. He slowly lost frames. This case was reported in BMC. Before age 4, this boy seemed completely typical. He walked at 13 months. He spoke words and short sentences by 18 months. His early development looked normal. And that's what makes it terrifying. Because the decline came after normal, slow, gradual, and easy to dismiss. Around age 5, kindergarten is when things changed. Not because he started falling, but because he stopped keeping up. Other kids finished tasks quickly. He got stuck. He took much longer, like his brain suddenly shifted into low gear. And one detail mattered a lot. His drawing and handwriting were unusually poor. Not just clumsy hands. It looked more like his brain was struggling to send the right commands. He knew what he wanted to do, but he couldn't organize the steps. So the early labels made sense. ADHD, learning disability, behavior problems. Those diagnoses are common, and from the outside, it truly looked that way. But here's the danger. If it's not stable, and it keeps getting worse, that's a very different story. Over the next year and a half, he didn't catch up. He kept declining. He became more awkward, less coordinated. Learning became harder, and his behavior became harder to redirect. By age 9, it was even clearer. He began losing language and losing control. He spoke less and less, not because he didn't want to, but because he couldn't. He started repeating what others said, like his language system was stuck in echo mode. His behavior also became repetitive, like a loop button was pressed. The same actions, over and over, hard to stop, hard to switch. And then came the biggest trap. Doctors ran many standard tests, and everything looked normal. Routine metabolic screening was normal. Blood and urine tests showed nothing obvious. Chromosomes were normal. Even the brain MRI looked normal. That's what makes NPC so deceptive. Early on, it may leave no clear marks on MRI. And the more you trust normal results, the easier it is to miss the real direction. The turning point usually comes from 2 major signals. Seizures, and a key sign that's often overlooked, slow vertical eye movement. This is called vertical supranuclear gaze palsy. VSGP. The eye muscles aren't weak. The problem is that the brain circuit controlling vertical gaze is failing. When seizures appear, walking becomes unstable, swallowing becomes difficult, and VSGP shows up too. That's when the alarm finally goes off. This may not be just behavioural. At that point, Targeted testing was performed. Blood or bone marrow suggested a storage disorder. Skin cell testing showed cholesterol buildup. Genetic testing confirmed a pathogenic NPC1 mutation, and the mystery finally made sense. He wasn't lazy, and he wasn't just psychological. His cells had a lipid transport problem, like a warehouse where shipments can't leave. They pile up, they overwhelm the system, and over time, they damage the brain. After diagnosis, he began Miglustat at age 11, along with seizure management and long-term follow-up. At age 12.5, something meaningful happened. He became more stable. He gained weight. His cognition and language improved. He regained some words. His mobility improved too. He moved from a wheelchair to walking short distances with a walker. And his seizures became more controlled. It wasn't a miracle recovery, but it was something powerful. On a slow downhill slope, someone finally pressed the brakes. For families living through this, even that is hope. Chapter 2. What exactly is NPC? Let's make NPC clear. This is not a mental health problem. It's more like a cellular warehouse overload. Many people assume Niemann-Pick A, B, and C are the same. They're not. Type C has a different mechanism. Imagine the cell as a city, and the lysosome as a shipping warehouse. Cholesterol and lipids get delivered there. They're unpacked, sorted, and then shipped back out to build cell membranes, myelin, hormones, all kinds of essential functions. NPC happens when the cargo gets in, but the exit route is blocked, so cholesterol builds up more and more, and the whole system becomes chaotic. Sometimes it affects the liver and spleen, but the most critical damage is in the brain. This shipping system depends on two partners. NPC2 is like the worker inside the warehouse, handing the cargo forward. NPC1 is like the gate at the exit door. If either one fails, cholesterol gets trapped. So NPC is not a nutrient deficiency. It's not missing cholesterol. It's cholesterol that can't move. It gets stuck, and it piles up, and the chain reaction goes further. The system can't clear waste properly. Recycling breaks down. It's like a city in gridlock. Garbage can't be removed. Cleanup shuts down, and the damage slowly spreads. NPC can start at many ages. Some patients begin in infancy with liver or bile problems. Others don't show symptoms until adolescence or adulthood. And then it looks psychiatric. So why does it mimic mental illness? Because the brain is extremely sensitive to lipid transport. First, communication between neurons destabilizes. Early signs can look subtle: worsening attention, slower learning, mood swings, impulsivity or aggression, and in severe cases, delusions, hallucinations, psychosis-like symptoms. Second, the brain's cleanup system is impaired. Neurons suffer when waste removal fails. Over time, they shift into chronic injury. Third, certain brain circuits are especially fragile. The cerebellum, eye movement pathways, swallowing and speech networks. That's why later, signs often include unsteady walking, frequent falls, slurred speech, choking while swallowing, seizures, and one major red flag: slow vertical eye movement, VSGP. Again, the eye muscles aren't broken. The brain's control system is. So how do we avoid years of delay? Think in 4 steps. Connect the clues, screen biomarkers, look for neurological signposts, then confirm with genetics. Step 1. Build the pattern from history and exam. NPC has 2 faces, a psychiatric mask and neurological signposts. The psychiatric mask can resemble depression, anxiety, mood instability, paranoia, hallucinations, social withdrawal. In children, the first problem is often school. learning struggles, attention issues, writing difficulties. The neurological signposts include clumsiness, unsteady gait, frequent falls, seizures, slurred speech, choking or swallowing difficulty, slow vertical gaze, and another unusual sign, cataplexy, triggered by laughter, a sudden loss of muscle tone after strong emotion, not a typical fall. Don't ignore organ clues either. Liver or spleen enlargement isn't required, but unexplained splenomegaly matters, unexplained hepatomegaly matters, or a history of infant jaundice or cholestasis, even if it resolved. Step 2. Screen blood and urine biomarkers, Oxysterols, Lyso sphingomyelin markers including Lyso SM509, and certain bile acid metabolites. These tests aren't perfectly specific, they're more like a filter. They help identify high-risk patients. Step 3. Look for key clinical signposts. Eye movement testing for VSGP is critical. MRI can be normal early on. EEG, swallow evaluation, and neuropsych testing help guide long-term management. Step 4. Confirm with genetic testing, usually NPC1 or NPC2. If results show a VUS, you may need biomarkers and functional cell testing. Treatment for NPC is evolving. We're moving beyond symptom-only care toward slowing progression and long-term management. There are 3 strategies: reduce incoming build-up, strengthen repair and cleanup systems, and stabilize neurological function. Miglustat works like traffic control. It tends to slow progression and help stabilize function. It does not guarantee reversal. Arimoclomol is like adding more repair crews. It is often combined with Miglustat. N-acetyl L-leucine, NALL, has shown signals of benefit in cerebellar symptoms, and supportive care is still essential. Seizure control, swallowing and nutrition support, rehabilitation therapy, learning and mental health support, fall risk management. Chapter 3. 2 common questions. First, if someone has only psychiatric symptoms, no enlarged liver or spleen, no VSGP, no gait problems, can NPC be ruled out?
No.
Late onset NPC can begin with psychiatric symptoms alone, and VSGP may not appear early, so the absence of classic signs does not exclude NPC. Second, can NPC look mild in childhood and only show its full picture in adulthood? Yes, and that is one of the easiest forms to miss. In many cases, it takes over 5 years from psychiatric symptoms to diagnosis. So why is NPC misdiagnosed as depression, schizophrenia, or ADHD? It's not because clinicians are careless. It's because NPC is an expert at disguise. Psychiatric treatment can even seem effective. Antipsychotics may reduce agitation. Antidepressants may blunt mood swings. Sedatives may improve sleep. And that can create a false sense of certainty. But NPC is a long-term cellular traffic jam. Early on, it only shows small cracks in mood and behaviour. The neurological signposts often come later. MRI and routine labs may look normal too, until one day it stops looking purely psychiatric. Cognition keeps declining. Walking becomes unstable. Swallowing and speech are affected, and vertical eye movement slows. That's when the key question appears. If this isn't just mental illness, could a deeper metabolic disorder be slowly damaging the brain? Chapter 4. The second patient. Teen psychosis first. NPC revealed later. This case was also reported in BMC Scene 1. In the ER, she stares at the wall and says, "The bugs are crawling. Can't you see them?" At 16, a girl was admitted to a psychiatric unit. The episode came on suddenly, like her world flipped into horror mode. She heard voices, like people nearby were talking, Even talking about her, she saw things that weren't there. Bugs crawling on the wall, strangers in the room. She believed she was being watched, followed, threatened. She was intensely anxious and agitated, restless, terrified, fear rising like a wave. Her MRI was normal. Her EEG was normal, so it looked like typical adolescent psychosis. But the real danger was this. It wasn't her first warning sign. The earlier clues were scattered and easy to overlook. Scene 2. Rewind to age 1. Her body had already signaled something. If you focus only on psychiatry, this becomes a mental illness story. But her medical history had unusual fragments. At age 1, she had unexplained splenomegaly. At age 4, it happened again. Her spleen size fluctuated. By age 6, it was even recorded as normal. These clues are easy to dismiss because they can be mild, they can change, they can disappear for years. And when psychosis finally erupts, no one connects them anymore. Scene 3. In school years, she wasn't a bad kid. She was slowly falling behind. She had mild developmental delays early on. Later, the issues looked like school problems, language difficulty, learning struggles. She needed speech support, more academic accommodations. She also had attention problems. She was even treated for ADHD. But socially and emotionally, she seemed mostly okay. So she was seen as a learning issue child, or mild developmental delay. But the key detail was this. Her cognition wasn't stable. It was declining. At age 7, her total IQ was around 78, borderline range. At age 13, it dropped to around 60. A clear decline. If you look at each point alone, it looks like learning disability. But together, it looks like the brain is slowly losing speed. Scene 4. At 11, she suddenly became very weak. She lost major motor function. It followed a mycoplasma pneumonia infection. She was diagnosed with a Guillain-Barré-related syndrome. After rehabilitation, she recovered significantly and returned to school. Many people would relax here. See, it was post-infection. She's fine. But NPC is deceptive. It can make you think the story is over, and then return years later with something much worse. Scene 5. At 15, she began declining again. Her walking became unsteady. Her coordination worsened. Swallowing problems appeared. She needed increased supportive therapy. But even then, there were no major psychiatric symptoms. So her life shifted toward more support, more therapy, more accommodations, until a few months later, at 16, psychiatric symptoms exploded. Scene 6. A full psychiatric collapse, hallucinations, paranoia, and panic. This wasn't just feeling down. It was a structured psychotic syndrome. Auditory hallucinations, hearing people talking. Visual hallucinations, bugs crawling on the walls, seeing strangers, paranoia and persecutory delusions, believing she was followed, watched, threatened, severe agitation and anxiety, fear, tension, restlessness. Once symptoms look like this, the clinical pathway almost always goes psychiatric first. She was started on a typical antipsychotics. Then came the confusing twist. Her speech became slurred. Doctors first suspected medication side effects. But after treatment, she looked even more neurological. So what was causing what? And this is a classic NPC trap. Medication effects and disease progression can look almost identical, especially when the disorder itself can cause swallowing issues, speech problems, and abnormal movements. It becomes easy to misread the direction. Scene 7. Then the key sign appeared. Her vertical eye movement slowed. VSGP. The eye muscles weren't weak. The brain circuit controlling vertical gaze was failing. It was like a road sign flashing. This may not be primary psychiatric illness. When clinicians finally put the pieces together, psychosis-like symptoms, progressive cognitive decline, a history of splenomegaly, VSGP, loss of motor function. Suspicion for NPC rose sharply. Cell testing suggested cholesterol accumulation. Genetic testing confirmed NPC1 variants. And the psychiatric story turned a page. It became a metabolic disorder story, where neurology, organs, and psychiatry overlap. Scene 8. Diagnosis found. But treatment access was complicated, because insurance coverage, indications, and availability still shape reality. Later, Miglustat became available locally. But the lesson remains: NPC isn't only cruel because it's rare, it's cruel because it hides. It wears psychiatry as camouflage. And when diagnosis finally comes, if patients still can't access disease-modifying care, that frustration can be devastating. In NPC, time is neurons. 1 year later can mean irreversible loss. Final thoughts. NPC often writes its first chapter in psychiatry and in school. Attention problems, mood instability, hallucinations and delusions, academic collapse, behavioral dysregulation. A normal MRI does not mean no disease. Normal routine labs do not mean no disease. The key to shortening delay is to put all clues on one map. Is there progressive decline, unsteady gait, swallowing problems or slurred speech, seizures, emotion-triggered cataplexy, a history of splenomegaly, and most importantly, VSGP. When suspicion is high, start with targeted biomarkers, then confirm with NPC1 and NPC2 genetics. Replace blind searching in the dark with a directed path to diagnosis and care. We are entering an era where progression can be slowed, where long-term management is possible. But access determines everything. Having a treatment is not the same as being able to use it. We need earlier recognition, more standardized testing, and more realistic policy support, so that lives that are slowly dropping frames don't lose functions and time that should never have been lost.
If you're interested in stories at the intersection of inherited metabolic disorders, IEMS, and mental health, including cases of metabolic psychosis, you can check out the full written version in the Junyi column.